Thyroxine replacement therapy is quite common and commonly seen, but we don't see combination treatment with the T3 and T4 often. So to know the usefulness about it, we have Dr. Prashanth to enlighten us on this.
So respected chairpersons and dear friends, at the outset I would like to thank Dr. Ganesh for having given me this opportunity. So what in the next 20 minutes or so I'll try to dwell into this topic and look at basically evidence for the combination of thyroxine and levothyroxine. Okay, we know that hypothyroidism is a very common condition. It's a condition which is caused by an inefficient production of thyroid hormones, leading to a generalized slowing of the metabolic process. And we all know that we have a primary hypothyroidism where the thyroid is at fault, or a secondary or tertiary hypothyroidism where the pituitary or the hypothalamus is at fault. The treatment of choice, as we all know, for hypothyroidism is levothyroxine sodium, which has a longer half-life, hence it is stable, long-acting, with an intestinal absorption of almost 80%. And the goal of treatment is to normalize TSH, which we do after 6 weeks to 2 months, and then if stable, even once in a year would do. Though we know that the generic brand are bioequivalent, but the bioavailability is different, and that is the reason that when you get normal TSH with one particular brand, it is better not to change the brand. The full replacement dose is between 1.6 to 1.8 microgram per kg. Since absorption is affected by food, then we know that it should be best taken in the fasting state. T3, which is now recently available in India, just to go through the pharmacokinetics, the half-life is around 1 day. It has to be taken at least 1 to 3 times daily, but the availability is much better off, but it leads to peaks and troughs. So, what is the limitation of LT4 monotherapy? This is a very old paper in 1970 when desiccated thyroid extracts were actually used for treatment of thyroid. When thyroxine came into, the levothyroxine sodium came into the market. Patients who were put on levothyroxine, even in May 1970, there was, it has been the experience that a small group of patients with hypothyroidism were not well with the thyroxine replacement alone. So these are the residual symptoms, what we call the brain fog, which may be a combination of mood problems, decreased energy, memory, sleep, etc. Many of the patients who are on thyroxine did feel that still their whatever sort of brain fog is still present in them. So that is some of the residual symptoms, and many studies have shown that the cholesterol as well as the LDL cholesterol levels are higher in patients who are treated with levothyroxine sodium. This is basically a systemic review of 21,000 patient record confirmed them. And there is one study where they looked at around 10,723 outpatients who were given levothyroxine sodium, and what they found is in patients who were on levothyroxine sodium, the use of statins were higher, and that is not only just immediately but also even 1 year after treatment started. And it also was true for the patients who had normal TSH levels. So even if the patient's TSH is normal, they had a higher use of statins. So what we would call the residual symptom, one is a cognitive component or what we call the brain fog. Then there may be some metabolic component also which may not be corrected after giving levothyroxine at what doses which we reach the TSH target. They may weigh little more, the cholesterol levels are more, and more of them would be on statins. So why is this happening? So this is a normal thing. We know that T4 and T3 are the hormones secreted by the thyroid. Only 20% of the T3 is secreted from the thyroid, and the rest of the thyroid T3 is made from deiodinization. D1 enzymes present in the liver and kidney, and the D2 in the and the adipose tissue and the skeletal muscle, etc. 20, that is almost 80% of the T3 comes from the D2 deiodinases present here. So when are these enzymes very important? They may not be, because when the patient has an adequate thyroid reserve and normal thyroid and pituitary functions, what happens is, even these are rat models where the deiodinase enzymes, they have zero activity of deiodinase enzymes, yet what happens is the T3 levels are maintained within normal limit. This is because of the feedback mechanisms, the amount of T3 secreted from the thyroid gland is increased. But what happens if you are devoid of any thyroid hormone, as we in hypothyroidism, where none of the thyroid hormone comes from the thyroxine, from the thyroid gland. So here we give the tablet. What happens here? Do we get the T3 which is required, or is there any difference? So this is one of the main limitations of levothyroxine therapies. Whenever you see patients, this is the same paper around in 1970, patients who were treated with levothyroxine sodium, if you look at their thyroxine levels and FT3 or T3 levels, the T4 levels always remain upper side of normal and the T3 always remain in the lower side of normal. And these are the various studies which did show. Most of these studies which are here in red shows that the T4 levels are normal. Even the NANUS database did show that the patients who are treated with thyroxine, the T4 levels, as you can see, are on the higher side, FT3 levels are on the lower side. And this is basically because one of the reasons is because this D2 enzymes in the pituitary, what happens is once this deiodinase acts, they become ubiquitated and becomes inactivated. This inactivated is much more prominent in the peripheral tissues than in the brain. So when the same amount of T4 is deactivated, it is more efficient in the hypothalamic pituitary axis, and then hence what happens is the T3 levels are normal for the brain. That's the reason that they do not increase it or decrease the TSH further, but at the same time you have a sort of what we call as a tissue hypothyroidism, though the TSH is within normal limits. You have some conditions where you have polymorphism of the D2. Here you have this polymorphism decrease the function by 20% and a polymorphism in D1 decrease by 50%, and this can also result in increased T4 and decreased conversion of the T4 to T3. So the plausible mechanisms when the patient is having normal T4 but is not satisfied is probably this tissue hypothyroidism, but there are other plausible mechanisms. One is the, as already mentioned, genetics, the alleles which are basically which are responsible for the deiodination. Second thing is we know that we do not have the TSH set point for an individual patient is it's individualized. That is, a person may have a normal TSH which is in the lower end of normal, and if we just go by general population targets, he may not reach his TSH. So in some patients, when you suppress the TSH just below normal, some of these symptoms disappear. Similarly, you know that we have a diurnal variation of TSH when TSH is higher in the morning and lesser when it reaches another by the afternoon. So when you give him thyroxine, there is no another for that, and that could also be a possible mechanism for symptoms. And some mechanisms have been proposed, like a poor converter who have a genetic inability to make sufficient T3 from T4. So let us go through some of the analysis and studies which have looked at the combination therapy in comparison to levothyroxine only therapy. So this is one systemic study which looked at the patients were blinded and they looked, they didn't know whether they were given LT3 or LT4 or a combination therapy. And though all of the things were almost similar, but what was most important is that patients preferred a combination of LT3 and L4 compared to LT4 alone, though the TSH everything was normal. So they didn't find a positive correlation with the LT3 dose, which may be requiring more further studies. And this another one good study, which is a crossover study in around 30 patients who were first given T4 and then they were crossed over to T3, and this study did not show any, there was no clear clinical benefit of the study from the formulation used. What about the randomized control trials? And most of the randomized control trials, you can see many randomized control trial meta-analysis, they did not show any benefit of a combination of LT3, LT4 compared to thyroxine alone. So this is one of the more recent studies. It's a very good study which looked at the 75 patients who were first given over a period of 22 weeks. 16 weeks they were on stable doses of either thyroxine or a combination of thyroxine and T3 and T4, or on desiccated thyroid extracts. So what they again found is that as a group the outcomes were similar among hypothyroid patients taking any of these, but though patients who were more symptomatic on this LT4 preferred and responded positively to a combination of LT4 and LT3. And what about meta-analysis? This is a meta-analysis of all these studies. I think 18 studies were included, and as you can see, we were looking at the clinical status, the quality of life, the psychological distress, depressive symptoms, fatigue. None of them actually were better off with the combination therapy compared to thyroxine, levothyroxine alone therapy. But again, a higher number of patients preferred a combination therapy. We don't know the reason for that. So what is the problem with the clinical trials is, one thing we should know is, though we tell LT4 they didn't prefer, they preferred a combination therapy, the result of treatment was equivalent. All of the things, you either use LT4 or a combined LT4 and LT3, the treatment was equivalent in both these groups. But there is a clear preference for combination therapy. The patients generally they felt better off with the combination therapy, and the problem again here is that when you use these trials, they did not specifically recruit patients with attention to persistent hypothyroid symptoms of dissatisfaction. So it was a general trial in all, with all patients who were on thyroxine. They did not look at patients who are particularly dissatisfied with only thyroxine therapy. So there is a possibility that most likely some individuals may benefit from combination therapy. They may not have been included in these trials, and hence we could not have an adequate power for it to prove that LT3 may be useful. There are no good statements from the American Thyroid Association, etc. This is the reason, they are still ambiguous and they have not given any, they are told that it's just an experimental therapy. This is the last update which came from the British Thyroid Association along with the Society of Endocrinology. What they suggested is, this guidelines came out in 2023. They suggested that some patients with confirmed overt hypothyroidism and persistent symptoms who have had adequate treatment with levothyroxine and whom other comorbidities have been excluded, a trial could be given of a combination therapy. So this trial with liothyronine should be shared decision between both the patient and the clinician. So what are the circumstances where it can be used is, one, the patient should be having a proven diagnosis of overt primary hypothyroidism, because many of our patients, because thyroxine TSH testing is done so very routinely, many of the patients have started on thyroxine and we do not know whether they are really hypothyroid. So if you want to prove that they have overt primary hypothyroidism, you have to stop the thyroxine, see whether the TSH rises, and then restart and confirm that they are hypothyroid. The second point is that hypothyroid symptoms should persist on when you are giving levothyroxine alone, and levothyroxine should be administered appropriately, the dose duration and the TSH response. We should try to keep the TSH less than 2 in such situations. And other comorbidities, because these symptoms are very, very non-specific. Any patient with a generalized arthritis, fibromyalgia, all of them will be having similar symptoms. They are non-specific, and hence you have to look for alternative comorbidities, and an endocrinologist is willing to initiate as well as supervise this trial which we are going to give. So the comorbidities which has to be excluded include celiac disease, perimenopausal estrogen deficiency, nutritional deficiencies, obstructive sleep apneas, mood disorders, etc. This is how they have advised to take. That is, you have persistent symptoms while taking levothyroxine. You confirm the diagnosis of overt hypothyroidism by documenting that TSH is greater than 10. If you cannot document it, maybe you will have to stop LT4 for a period and then reassess TSH. First, you optimize the levothyroxine so that you reach the reference range for at least 6 months, and also assess for other non-thyroid comorbidities, which includes, as mentioned, vitamin deficiencies, autoimmunity, etc. Then you have to discuss the trial of giving this combination therapy. During the trial, you have to, the risk of treatment, generally most of the meta-analysis and long-term studies have not shown any higher risk, but we know that T3 is a hormone which increases rapidly, so that there may be variations. So patients with cardiac disease, elderly patients, it might be a risk for cardiac events as well as osteoporosis, so that should be discussed. We give the duration of the trial should be for at least 6 months, and if the patient is not responding, then it is better to stop, and then monitoring the plan after once the patient has attained the effect. So how do you substitute? So if you have a levothyroxine dose, the LT3 dose should be 1/17th of the current dose of levothyroxine, and then the thyroxine dose should be reduced by 3 times the LT3 dose. For example, if the patient has a baseline dose of 100 microgram, then you give 85 micrograms, and then 3 times the 5 micrograms. There 15 micrograms are from 100 micrograms should be reduced. If the patient is on 125, 107.5, and if the patient is 150, you give 125 microgram of levothyroxine and 10 microgram of levothyroxine, LT3. But again, many of the times it is better to split the dose of LT3 because it has a shorter half-life. If you give it as a single dose, you might have higher variations in the serum levels. Then review the efficacy at 3 to 6 months, and if no subjective benefit is present, then stop treatment. Where should it be avoided? In patients with underlying cardiovascular disease, pregnancy, older patients. It may not benefit at all in patients who are already well on LT4 therapy or who have only mild hypothyroidism. They have enough of endogenous T3 protection. How do you adjust the dose? So if the TSH is slightly elevated, then increase the T4 slowly. It's mildly elevated between 5 to 10. You increase only the dose of T4. It's above the reference range, then both have to be adjusted in the ratio of 13:1 to 16:1, and normal continue the same dose, and if it is below normal, then you should reduce the T3 dose by 2.5 micrograms. So with all this, still we do not have a definitive criteria where you can use. So the most important thing is most of them are this mood disturbances, etc. So the quality of life questionnaire should be a primary outcome in many of these clinical trials. The other metabolic efficacy outcomes should include serial measurement of body weight, the lipid panel, cardiac efficacy outcomes, musculoskeletal efficacy, and cognitive assessment, as well as a large long-term RCTs are needed if you need to prove that LT3 may be useful. So in the past, when there was only desiccated thyroid hormones, our basic monitoring was clinical with the BMR, etc., and the iodine was monitored, and the aim was to prevent thyrotoxicosis when you give desiccated thyroid extract, etc. Then we have come to the recent past where levothyroxine is used, and the monitoring was to be with the TSH and to correct hypothyroidism. But now future, maybe we'll have to give the medicine based on the genotype, etc. The goal should not just be the TSH, it could be the T4 T3 ratio or T3 dependent markers, which includes TSH as well as the basal metabolic rate, serum lipids, etc., and subjective symptoms where we need a we need a very good sort of questionnaire to look into. And the goal here will be not only euthyroidism from TSH point of view, but also tissue euthyroidism. So I'll end. The aim of treatment in hypothyroidism should be to maintain normal TSH levels, but also to achieve symptomatic relief and satisfaction. There may be a subset of patients who may benefit from combined T4 and T3 treatment. Still, it's a very difficult research area, and because there are no hard primary endpoints. So still it remains an art more than a science unless we have more objective tools to assess the treatment effect. So I would like to thank Dr. Titu, from whom I took some of the slides.
Questions from the audience?
No, the target TSH, ideally the TSH for a younger person should be less than, we try to maintain it below 2.5. So in patients who have symptoms of hypothyroidism, in spite of you reaching the target, there are recommendations that you can try to reduce the target below normal, but more than 0.1. That is, it should not be overtly suppressed, but mildly suppressed. In some patients, this may result in betterment of symptoms, but you are at the risk of two things. One is this cardiac arrhythmias, especially in elderly patients, and in long-term treatment, even osteoporosis in women, postmenopausal especially. Yeah, that is still not, when you are treating, we use the morning TSH, but as patients, they do it at any time, because you might have a higher TSH in the morning. But here the problem is when you are giving exogenously, how much it affects, we don't know.
Any endocrinologist who has prescribed this combination therapy?
So we don't have combination therapy here. We have T3 separately. I don't have much experience because we don't have indications for doing that. Where we do use T3 more frequently is when a patient wants a surgery and his thyroid function is low and he wants a semi-emergency surgery, you can give T3 to normalize the thyroid function faster. especially the patient who wants radioactive iodine, where you have to stop this thing to take a scan. Radioactive iodine scan, where you have to stop the thyroxine, so you'll have to stop it for 4 weeks to 6 weeks. Instead, you can start on T3 and maybe in 1 or 2 weeks you can, so the patient may not be symptomatic for a longer time.
In your practice, when do you ask a TSH? How often you ask for a TSH?
I think the first TSH I ask, not in pregnancy situations, otherwise is around 2 months, 1.5 to 2 months, then 3 months, then if 2 times it is stable, then every 6 months. Because they recommend only 1 year, but most of the patients, by the time they would have gone for some other treatment. If you tell them to come after 1 year, they would have either stopped it or taken some alternative medicine. So you should keep
Ideal time of checking for TSH?
Ideally, do it in the morning before giving the thyroxine, because I usually do the T4 and TSH just to find out how much of you have overt
on empty stomach.
On empty, ideally, but then most of
the labs will be opening only at 7:30.
Yeah, that's right. Does not make much of a difference, because so any time would do, but ideally I told it should be in an empty stomach. But I think it doesn't make much of a difference.
Thank you, sir. If there are no other questions, we close this session.